Hi everyone, my name is Avi Rana and this is my final project. I'll be doing it on an knee X-ray protocol guide. So the goal behind doing this is making sure the patient radiation dose is reduced by reducing X-ray knee repeat rate. We're gonna better workflow by increasing communication gap between the physicians and the X-ray technologists, and we need to make it easier for anyone rotating through Harborview Medical Center, such as medical students, any new physicians, any med students, and they can always look into this guide, which will be available for them to clear up any miscommunication. The departments we do have are the emergency department, the main department, the orthopedic department, and the surgery department. And each department does knee protocols very differently, and some have specialized X-ray projections to show different parts of the knee. So we will be talking about each department here. We'll also be talking about the X-ray projections, and these projections are going to be different with different departments. But the most common one is the AP and the lateral projections. The AP is the frontal view of a knee. It just means antero-posterior. It means the X-ray is going to enter through the anterior portion and exits through the posterior. It's going to be a frontal view of your knee. A lateral slash cross table. Lateral just means it's a side view of the knee is going to be shown. And then we have obliques, 45-degree angle to show the knee in a different way. It just shows any hidden fractures that can't be seen on an AP or a lateral. Sunrise view is focused on the patella, and this is done usually if there's a known fracture of the patella or if there's any suspicion of a fracture. And then we have a tunnel or a notch view done to see the space between the knees. Alright, going on to the emergency department, we have 4 views that we're going to be doing. AP, internal, external obliques, and a cross-table lateral. Cross-table laterals are done to show any fluid levels or any trauma that's caused on the knees, basically. Knee reductions and traction pin placements are more specialized towards trauma, so the ED department will be doing these. So anytime the bone is severely fractured, they would have to reduce the knee first, make sure it's lined up properly, and then they would put a pin in. It has to go through bone, and then they would put traction to put weight to make sure it's the reduced knee will stay reduced, and it doesn't cause any more internal damage if the knee was badly broken. So the 4 view protocols for knees are AP, which is this one right here, oblique, another oblique, so this is your internal oblique, your external oblique, and your lateral side view, frontal view, 2 obliques, internal, external, and your side view. Same thing here, that was the right, this is the left, AP, internal, external, and then your side view here. So this is what we were talking about with the pin placement. It's going through bone. We can't really confirm that it's going through bone unless we see a side view here, but the knee is nicely lined up. We got traction going in, pin placement going in. There's weight being put in over here to make sure the bone does not move in there. There we go. The lateral view, the cross table lateral. See if there's going straight through bone there. No skin. If it's not going through bone and if it's going through skin, then it's bad, right? Because then it's just gonna pull the skin, and it's gonna cause much more damage there. So we want to, as soon as they put the pin there, we come in, we take an X-ray, make sure it's going through bone and not through skin. That is important. And then here we go. This patient was a motor vehicle collision. This is the AP frontal view of the knee, um, severely fractured here. And now we have external oblique. The bone is not lined up, so it's not reduced. Um, yeah, this one's really badly broken. There's another internal knee of the same patient there. Just I skipped one there. I think okay. Sorry, the trauma. This is a trauma lateral knee. Um, supposed to look lateral, but obviously it's severely broken here. So that's the patella. That's the knee. That's the lateral view of that. So we have the pre and the post reductions. So this would be the pre-reduction. You see how it just smushed over here, and then after post it looks much better, much cleaner. Just them pulling the bone to line it back up um, gets it looking all clean, and all these bones that are broken here won't cause any more damage than it would if the patient's just left like this. Um, it could easily damage muscle, cause more internal damage for sure. So pre versus post here, much cleaner. Same thing. This is lateral view now. This is the pre-reduction. Looks like nothing here. Can't tell anything here. Um, this bone is straight, then it just smushed up here. But then over here, you can tell it's lined up better, even though this is broken here. You can see this knee part is lined up. You can actually see the condyles stacked up here. So this is a good post-reduction image, a lateral image of the knee. Patient is ready to go for surgery. Here we go, talking about the trauma obliques earlier. The 45-degree angle, the fibular joint space is open, shows the tibial right here, this underlying fracture that would not be seen in an AP. All right, moving on to the main department. This department basically focuses on inpatient care. We usually call down patients uh, from the floors and get their X-rays done here. The usual views done are AP and lateral views, unless the physician is going to ask for any specialized view, such as a sunrise. And the sunrise view is done to see any fractures of the patella. So this is a main AP knee. This is a basic frontal view of the knee, and this is a basic frontal view of your, basic side view of your knee. And this is just showing your knee, your patella. You see a little fracture here, which means you're going to be needing a sunrise view, and that's what it looks like. Just like the name says, it just looks like the sun is rising, and it's focused on your knee patella. Moving on from the main to the orthopedic department, we have orthopedic trauma and also the clinic department, which is um, same department but does things a little differently. The trauma orthopedic department does AP and lateral, and the sports orthopedic clinic department is going to do the PA, AP, lateral, and sunrise, 4 views. So this is basically a device focused on orthopedic department, so this is specialized towards them. It's a knee measurement device. It's usually done for any future planning for knee replacements, and they'll usually do it weight bearing. So it's AP lateral and weight bearing images here. Bilateral PA views are required to measure the space between knees. And this ball, this metallic ball, is measured at 1 inch, and all metallic balls are 1 inch. This is what it'll look like. You have PA bilateral knees, right and left. They usually try to see their joint space here. It's That's a PA, and this will be a cross table lateral. Just again trying to measure the joint space, measure the whole knees width right there, and that's what a knee replacement looks like. That'll be your AP knee replacement, followed by the lateral knee replacement, and moving on to surgery. So surgery, you have a sterile field. Few things to take away from surgery. Sterile field, you want to make sure you don't touch the sterile field by any means. You want to know what's sterile, what's not sterile. And we come in with a C-arm, use live fluoroscopy. The views we'll be doing are AP and lateral. So that's the C-arm. It's called C-arm because it's shaped as a C. And you have the blue, that's sterile. The slightly grayish blue is the unsterile portion. So you want to know sterile versus unsterile. And that'll be your AP projection, which will look like that. AP of the knee in surgery. And then this is your lateral. Your C is going in down that way, coming in this way. Sterile field again here. And that's what that will look like. So we talked about all the views, all the different projections and different departments here, but we need to talk about how they're formed, and that's usually done by the control panel, which controls the KVP and mass. KVP is basically the kilovoltage peak, which basically controls the quality of the image, and mass is milliamperage per second, which controls the quantity of the image. And obviously the correct technique is required for a good image. Too little or too much of a technique is always going to hurt the patient. If there's too much, you're giving the patient a lot of dose. If there's too little, the image is not diagnostic enough, so you would have to repeat it, again giving the patient more dose. So it's very important to know what's your protocol technique. For a knee technique protocol, this is overall usually for a standard patient who is average. You shoot them at 60 at 3.2 for AP, oblique, and a lateral. Sunrise a little bit more at 66 at 4.0 because it's more focused, so you want to bump it up a little bit more. And for children, the technique is going to be much different because children are smaller, and if they're smaller, that means less is required. For preemies to 4 months, you do 54 at 1.6. For 4 months to 12 months, you do 56 at 2.0. For 1 year to 6 year, you do 60 at 2.5. And for 6 years to 12 years, you do 60 at 3.2. 5-year-old AP knee, oblique knee, external oblique knee, and a lateral knee. The bones are still forming, which is why you see all these epiphyseal plates not fully formed. That's what that looks like. So now this is just a little more data of repeated trauma exams that we have, and you can see the knee lateral is much higher at 61 repeated on trauma, and much more done at 431, and the percentage of repeat was at 14.15. Looks like the highest repeated rate was a scapula, but again, less done here. Same thing here, main exam, 2 out of 11. Most repeated orthopedic exam, 16 out of 100 in ortho versus pelvis 33. So ortho pelvises were done more. And the future goals is to have this PowerPoint available in all the departments to reduce the rate of x-rays repeats caused by miscommunication. And if this goes well, I'm going to do more anatomy parts. And that's all, folks. Hope you guys enjoyed. Thank you all. Thank you so much.